my dear colleague and learned audience. Very good afternoon. Me, Dr. Sohel Mridha, going to present my case. My case is Mr. X, 55 years old, hypertensive, non-diabetic, smoker, admitted into NICBD with old MI inferior with post-MI angina. He has a history of fracture both femur and right radial by a road traffic accident 3 years back. On examination, findings are normal, and investigation echo is normal, EF 56%. We have done coronary angiogram on left system, LAD 30 to 34%, and OM on 70 to 80% on right system. RCA is 99% stenosis. Then we plan to do PCI and stenting to RCA and OM on. We proceed to PCI to RCA through left radial route, but could not negotiate, and we felt resistance in the forearm. Then we check and dilute the diluted dye with. We cannot negotiate wire. Then we give diluted dye to radial route, and there is a radial perforation. Then we are in travel. What should we do? Should I proceed or not? Should I switch to femoral route or postpone the procedure? Then we give intermittent blood pressure curve to seal the radial artery perforation. What do next? We decide abandon the procedure or shift to transfer the femoral route or continue the procedure with the same route. We look the patient. Patient is minimal symptom in the forearm, no swelling in the forearm, and patient is hemodynamically stable. So we decided to continue through the transradial route with intermittent pressure, compression in the forearm with BP cuff. Then we decide to balloon-assisted tracking. 1.5 to 12 millimeter balloon was taken. It was partially protruded from the tip of the catheter and was inflated with 3 ATM, and then whole system was tracked over the wire. Balloon-assisted tracking is a novel method to perform transradial procedure in patient when there is a difficult vascular anatomy, severe tortuous radial artery spasm. In addition, it can serve as a bailout technique, such as in radial artery dissection or radial artery perforation. Here it acts as a intravascular hemostatic device, and it can avoid razor effect. Then we complete the procedure, and we check after procedure completion, there is sealed up of perforated radial artery. This is the final result. Radial access complication, it may be inter-procedural complication and post-procedural complication. Inter-procedural complication may be bleeding or non-bleeding. In bleeding, it is a radial artery perforation may occur. In Tejas Patel et al. Papers, radial artery perforation occur 0.09%. Predisposing factor for radial artery perforation, a small radial artery, tortuous radial artery, hypertensive patient, RA loop, forceful manipulation of the guide wire, and reuse of catheter or diagnostic wire. When suspect to radial artery perforation, excessive resistance in the passage of guide wire or catheter, complaint of significant local pain in the radial or brachial region from the patient, development of expanding hematoma. Radial artery perforation, wire is proximal to perforated perforation. If yes, then seal perforation with the technique, bad technique may apply, or guide catheter or long sheath catheter. Then continue the procedure, and final angiogram if performed, then follow up with compression bandage. If wire is distal, then able to advance wire. If no, we can heparin repairs with protamine and hemostasis, compression bandage, and hemostasis with prolonged balloon inflation, and surgery consultation, and then stop the procedure and post-procedure follow-up. Preventive measure for radial artery complication, pre-procedural measure, inter-procedural measure, and post-procedural measure. Pre-procedural measure can be taken if there is a risk of complication for radial artery perforation or others, then we can choose alternative access. We can also use ultrasound guidance to minimize the arterial injury and to avoid repeated puncture, appropriate sedation and analgesia and nitrates. Interprocedural measure can be taken: insert a smallest possible hydrophilic sheath, use J-wire, use balloon-assisted tacking to avoid a reserve effect, avoid excessive catheter torque to reduce the potential catheter kink, etc. Post-procedural measure, it can be done to avoid prolonged compression device duration, close vigilance to access site and assessment of the development hemostasis, and educate the staff for complaint of assist early identification and management, involvement of the interventional cardiology for the timely stabilization. Take home message: though complication incidence is low, but by transradial approach, perfusion may occur. We should be cautious about complication during, before, and after the procedure. When radial artery perfusion occur, we need not abandon the procedure. Rather, after managing the complication, we can continue the procedure by the same route. This is my our team with my respected teacher, Professor Mridha sir, and our staff. Thank you.